Every day, the kidneys process a massive vascular load, filtering the entire body's blood volume approximately 60 times. To manage this workload, the kidney asymmetrically distributes its blood flow. The outer renal cortex receives over 10 times more blood than the inner medulla. This entire supply enters through the concave hilum, the central gateway where the renal artery, renal vein, and ureter converge. Each kidney contains roughly 1.25 million functional units called nephrons. These structures are the microscopic factories responsible for processing the incoming blood. The journey begins as a single volume of plasma enters the afferent arteriole, the entry point to the renal corpuscle. This macroscopic architecture is engineered to distribute high-pressure arterial flow into millions of localized filtration sites simultaneously. Inside the corpuscle, the glomerular capillaries are caught in a pressure trap between two arterioles. This arrangement maintains the high hydrostatic pressure necessary to force plasma across the filtration barrier. The first layer of this barrier is the fenestrated capillary endothelium, in direct contact with incoming blood. These pores act as a physical sieve, allowing water and small solutes to pass while blocking larger elements like red blood cells and platelets. The second layer is the glomerular basement membrane, or GBM, formed by the fusion of the capillary and podocyte basal laminae. Within this membrane, a meshwork of type 4 collagen and negatively charged glycosaminoglycans physically and electrically repels large plasma proteins like albumin. The final layer consists of visceral podocytes. These cells extend interdigitating processes called pedicels that wrap entirely around the outer surface of the capillary. Bridging these pedicels are nanoscopic slit diaphragms. Utilizing proteins like nephrin and podocalcin, they create a final negative charge barrier to refine the filtrate. Between the capillaries, mesangial cells provide physical support and actively phagocytose debris to keep the filtration slits clear. This combination of physical pores and electrical charges allows the kidney to extract metabolic waste while meticulously retaining life-sustaining proteins. In glomerulonephritis, circulating antibody-antigen complexes from an immune reaction become physically trapped within the glomerulus. This accumulation triggers a local inflammatory response that damages the filtration slits and compromises the barrier. Diabetic glomerulosclerosis presents a different failure, where the GBM undergoes progressive thickening and sclerosis. When the barrier's structural integrity is lost, large plasma proteins leak into the urine, a clinical hallmark known as proteinuria. The chronic loss of these proteins disrupts the blood's osmotic balance, leading to systemic edema and a progressive decline in renal function, requiring clinical intervention. Roughly 20% of the initial plasma enters the proximal convoluted tubule as filtrate. Here, the epithelium shifts to a simple cuboidal layer. These cells feature a prominent brush border made of thousands of long microvilli. This brush border maximizes surface area, allowing the tubule to reclaim 100% of organic nutrients like glucose and amino acids. To power this high-capacity transport, the cells are packed with mitochondria. These provide the ATP necessary to actively pump 2/3 of the filtered water and electrolytes back into the blood. The PCT also actively secretes organic anions and cations from the surrounding capillaries directly into the filtrate. Because this pathway handles a wide range of molecules, it is the body's primary mechanism for clearing various drugs and antibiotics. The PCT acts as a high-volume processing center, reclaiming bulk plasma components while actively purging specific chemical toxins. The tubule then dives into the medullary pyramid, narrowing into the simple squamous epithelium of the thin descending limb. As the filtrate turns and moves through the thick ascending limb, cuboidal cells actively pump out sodium and other ions. This active transport creates a hyperosmotic gradient in the deep medulla. The vasa recta capillaries descend alongside these loops to support the tissue. The blood in the vasa recta flows in the opposite direction of the filtrate. This countercurrent exchange preserves the salt gradient rather than washing it away. Within these deep vessels, oxygen tension is naturally low. In sickle cell disease, this environment causes erythrocytes to sickle, leading to the renal infarcts seen in sickle cell nephropathy. This precise architectural alignment between the tubule and capillary is what allows the kidney to concentrate urine and prevent rapid dehydration. Returning to the cortex, the ascending limb contacts its parent glomerulus. Here, tubule cells thicken into the macula densa,
monitoring sodium and chloride as a proxy for blood pressure. A pressure drop triggers adjacent juxtaglomerular cells to activate their secretory phenotype. These cells release renin, an enzyme that initiates a systemic hormonal cascade to cause vasoconstriction and raise blood pressure. This feedback loop transforms the kidney into a master sensor that actively regulates systemic cardiovascular volume. Finally, multiple nephrons merge into the collecting ducts, which descend once more through the hyperosmotic medulla.
These ducts are composed of pale principal cells, which contain internal reservoirs of aquaporin water channels. When the body is dehydrated, antidiuretic hormone triggers these vesicles to fuse with the apical membrane, creating open channels that pull water out of the filtrate. Interspersed intercalated cells work in parallel, secreting hydrogen or bicarbonate ions to maintain systemic acid-base balance. The collecting duct is the final regulatory gateway that determines exactly how much water is reclaimed before the fluid is excreted. Once the fluid drips down into the minor calyx, it is officially considered urine, a highly concentrated cytotoxic waste product. If calcium salts or uric acid precipitate here, they form kidney stones, which can obstruct flow and cause severe localized pain. The ureters and bladder are protected by urothelium, characterized by large, superficial umbrella cells. These cells feature an apical membrane packed with rigid uroplakin plaques, creating a nearly impenetrable barrier against the urine. When the bladder empties, these plaques fold inward at their hinge regions, reducing the cell's surface area to prevent damage. This dynamic folding armor is the only thing preventing concentrated urine from osmotically pulling water out of the surrounding tissues. The journey from the glomerular filtrate to concentrated urine is driven by a series of highly specialized epithelial adaptations. Every shift, from the podocyte filtration slit to the uroplakin plaque, serves a strict physiological requirement. The coordination between these cellular geometries and physiological demands allows the kidneys to regulate systemic blood volume and chemical homeostasis minute by minute.